Good evening, all. It's a special privilege and honor to start this new series, which is going to be over next 6 months, or 6 series over next 12 months. A great initiative of IAOHNS by the most energetic chairman, none other than Kameshwar sir, and of course Vijay, ably backing him up all the time. I feel very honored to kick off this new series of difficult situations in head and neck surgeries, and in particular today's topic is that of difficult scenarios in cochlear implant. And none other people could be on this. There were two big stalwarts. One, I can say, a practical man who has probably done loads and loads of surgeries, and the other man who can read into the body far better than anybody else. That is Mohnish. I've seen his book on radiology of temporal bone. Brilliant, Mohnish. So I'm so happy that these two guys are taking you through to the difficult situations in cochlear implant surgeries. Thank you again, once again, for IOH and Mohnish and Vijay Krishnan in particular. Over to you, Mohnish. Mohnish, can you start? Vijay?
Mohnish?
Mohnish, you are muted.
Yeah.
You can unmute yourself.
Can you hear me, sir?
Yes.
Yeah, now you're on, Mohnish.
Good evening, everyone. And indeed, it's a privilege to have Madan Kapre, sir, introducing this.
Audio is getting cut.
Mohnish, we are not able to hear you.
We can't hear you, Mohnish.
There is some problem with my connectivity, probably. Can you hear me now?
Yeah. Now we can hear.
Very clear now.
Sorry. Yes. I was saying that, just thanking Dr. Kapre, sir, Dr. Mohan, sir, Dr. Vijay, and Indian Academy of Otorhinolaryngology, Head Neck Surgery, and GSK for, bringing out this series. And today's event is going to be on cochlear implants, and none better than Dr. Medikeri, sir, to start off. And he's going to deliver a talk on cochlear implantation, candidacy, and beyond. Sir has been practicing in Bangalore and his own hospital, medical specialist, super specialties ENT center, and he has been the past president of Cochlear Implant Group of India and is presently the president-elect of Association of Otolaryngologists of India. He has mentored many centers and has always been there to help us out. I have myself disturbed him many occasions. So it's wonderful to hear such a start of talk from Dr. Medikeri, sir. Over to you, sir.
Thank you, Dr. Mohnish. At the outset, I would like to thank the IAOHNS and the GSK people for arranging this webinar on cochlear implantation. At the outset, I would also like to thank Madan Kapre, the president of the association, for his kind words and introduction. So I will share my screen now. Can you see my screen?
Yes, sir, we can see.
Okay. Yeah, at the outset, I will start my presentation. This is on cochlear implantation, candidacy, and beyond. So I would like to share some of the situations which we had faced. As you know, the impact of untreated hearing loss can be very much. So people believe that hearing loss can lead to, it will affect the relationships, it will lead to withdrawal from the society and exclusion from the society, being secluded. And sometimes it will also affect the communication with your loved ones, and especially the senior people, even reduce the job opportunities or job prospects. Of course, in children, it will definitely affect the speech and language development and their academic career. So if you don't attend to this hearing loss, it will be $1 billion loss, which you can save by identifying this hearing loss, both in children as well as adults, and attending to the needs to improve. All of us know that the possible benefits of cochlear implants in children are this better speech perception, language development, educational benefits, and also the psychosocial benefits. And the same thing with adults. Even with adults, they can have a better speech perception in quiet and noise. There'll be a quality of life improvements, the psychosocial benefits, as well as the improved ability to work, as well as the cognitive power will be much better. So with these things, the implant candidacy evaluation, we have mainly two audiological criteria, audiological evaluations and radiological evaluations. Of course, the other evaluations like speech evaluations, psychological evaluations, and so many others will come down the line. So coming to who is the candidate for cochlear implant, if we go through these audiograms, as you see in A, you have a severe to profound hearing loss in both the ears. In B, you have a good low frequency hearing, whereas the high frequency hearing has gone to severe to profound. Or C, where there is 1 ear he has a moderate degree of conductive loss, and the other ear has got severe to profound degree of sensorineural hearing loss. Whereas in scenario D, has a one normal ear, whereas the other is the profound sensorineural hearing loss. So out of these, who is the candidate for cochlear implant? Of course, all are potential candidates for cochlear implant. All these patients. As for the first one is concerned, it is a standard criteria that bilateral severe to profound hearing loss across all frequencies is a candidate for cochlear implantation. Whereas the second one, where there is a normal mild loss in low frequencies and severe to profound degree of hearing loss in the higher frequencies. So these are again a candidate for a hybrid hearing, or what we call as an electroacoustic hearing, where the high frequencies can be benefited with the cochlear implant and lower frequencies can be benefited. Or even the cochlear implant with a shorter electrodes like hybrid L, where the higher frequencies can be amplified or heard better with the cochlear implant, and there is no need to amplify the low frequencies. The third variety is where there is an asymmetrical hearing with one ear better than the other. So these candidates are good for the bimodal hearing. I mean, cochlear implantation on the profound hearing loss side with a hearing aid on the moderate degree of hearing loss. And the fourth option will be where there is a one normal ear, the other is a profound degree of sensorineural hearing loss. So of course, there are three options in this scenario of single-sided deafness. Either they can go for a cross hearing aid or a BAHA, bone-anchored hearing aid, or third one is the cochlear implant itself. Of course, the first two options, they will not have a true binaural hearing. They will have a pseudo-binaural hearing. Whereas with the cochlear implant, they will have the true binaural hearing. So the current indications as per the FDA guidelines, there are adults with moderate to profound sensorineural hearing loss in both ears with limited benefit from amplification, defined by the preoperative test scores of less than 50% sentence recognitions in the better ear and less than 60% in the opposite ear binaurally. Whereas in children from 2 to 18 years, a severe to profound sensorineural hearing loss in both ears and limited benefit from binaural amplification with MLNT score of less than 30%. Or even younger children from 9 months to 24 months, a profound degree of sensorineural hearing loss in both ears with limited benefit with binaural amplification. These are the candidates for cochlear implantation. So over the last 4 decades, as you know, we started off first with implanting adults with profound sensorineural hearing loss with the unilateral implants. And later on, this was put out to the children. So children with bilateral profound hearing loss were implanted unilaterally. And over a period of time, then we started implanting children with profound hearing loss with multiple other disabilities. And gradually then we came across doing implanting both the sides, the same patient. So bilaterally implanting children or adults with bilateral profound sensorineural hearing loss. So as we went further, so of late we have been also implanting recipients with more residual hearing by using the hearing preservation techniques, both the surgical technique wise as well as the electrode selection wise. And this has ultimately led to using this cochlear implant for a single-sided deafness, though in our country still this single-sided deafness has not come into a very regular practice, or even if you advise for the many patients with single-sided deafness, there are few takers for the cochlear implant. So the radiological evaluation of this cochlear and cochlear nerves, we require a high resolution temporal bone scans of 0.625 mm cuts, and 3 Tesla MRI imaging system is preferred for both inner ear examinations as well as the cochlear nerve identification. And oblique sagittal reformatted images are very useful, which are perpendicular to the course of the 7th and 8th nerves in the IAC as well as the cerebellopontine angle. So with these evaluations, we have a well-known classification of cochlear malformation by Sanaroglu, which he describes into 8 varieties. All of you know about this mostly. Why I showed this cochlear implantation, which I'm going to talk next how. I'm going to cover mostly some of these anomalies, hypoplastic nerves, ossified cochlea, or a post-meningitic hearing loss, or children with multiple disabilities, and bilateral implantation. In time permits, maybe I might speak a little bit on hearing preservation in cochlear implantation. So in cochlear anomalies, there are certain challenges in managing these inner ear malformations. Of these, the decision making for surgical approach and the type of electrode selected for each malformation is different. And choosing the current implantation method, whether it is cochlear implant or ABI, these are very 2 important challenges while dealing with cochlear malformations. Some of these cochlear malformations, as you have seen, they are the definite indications for auditory brainstem implants, like complete labyrinthine aplasia or rudimentary otosis, cochlear aplasia, or cochlear aperture aplasia and nerve aplasia. So here there is cochlear implantation doesn't have any role. Whereas there are other indications like cochlear nerve deficiency or incomplete partitions or a cochlear hypoplasia with hypoplastic nerve. So these are the possible indications for auditory brainstem implantation. That means one can give a try of cochlear implantation in these cases whenever it is possible before going for the auditory brainstem implantation. So coming to this one of the malformation like the common cavity, it is a single ovoid cavity as you see here, representing both cochlea as well as the vestibule. Usually, the location of the common cavity could be anterior to the internal auditory canal level, but majority of the time it's in the middle or it is in the posterior part, as you can see. So cochlear implantation results in case of common cavity in acoustic stimulation, whereas there is a similar malformation called as the cochlear aplasia with a vestibular dilatation. Sometimes it can be mistaken for this. So where there is no functional stimulation of the acoustic system will happen. So one should be careful about these things. So there are various audiological findings in these cases. So one should have an hearing assessment which indirectly gives an estimate of the cochlear fibers within this cochlear vestibular nerve if you are not able to see a cochlear vestibular, the cochlear nerve completely. And also when you try with the hearing aid, one should look for the behavioral response and language development in these cases. So the management will be the cochlear implant surgery. In this case, will be a transmastoid labyrinthotomy with a straight electrode. That is a non-modular hugging electrode, as it is a common cavity and there is no modulus. If there is insufficient hearing and language development with CI, so one can think of doing a contralateral ABI in these cases. But if the cochleovestibular nerve itself is absent or there is no interlotary canal, then ABI will be the only option. So one of our child, a 3-year-old child, male, having a bilateral profound sensory hearing loss, who was fitted with hearing aids and had undergone therapy for almost a period of 1 year. He did not show much speech and language development. Neither his aided audiogram showed any sufficient gain with the hearing aids. When the radiological evaluations were done, bilateral common cavities were found in these cases with a thin cochlear nerve on the right side and absent nerve on the other side. As you know, initially in the earlier part of evaluations, they used to try the hearing aid first and the radiology used to be done later. But now one should do the radiological evaluation as soon as a bilateral sensorineural hearing loss profound degree is found out to avoid such delay in intervening these children. So this was the CT scan, what I showed a common cavity, and this was a MRI scan. This was a common cavity which is seen, and you could see a nerve coming and going to the cavity. But as I said earlier, this is lying posterior to the interlotary canal. So I would have been happy if it was in the middle or it would have been anterior. In a common cavity, even if there are cochlear fibers, they will be more located in the anterior wall of the cavity rather than in the posterior wall of the cavity. So that will be, this is one of the videos which exactly did like this. This is courtesy Dr. Milind Kirtane. We did a labyrinthotomy, a similar way. I don't have a recording of my surgery, but it was exactly in the similar way done. So you do a labyrinthotomy where in the region of the lateral semicircular canal to open the cavity. If you do a posterior tympanotomy, you will not see anything in the midline. So here it is a straight cochlear electrode is used, straight array, and one end is holding the tip of the electrode and with the other the basal part, so that the 22 electrode and 1 number electrode may be just at the outside of the cavity. And this was our patient's findings on the table, what we got the neural responses, except the 22nd and 1st, we could find all the responses, and this was the X-ray showing the electrode being inserted into the common cavity. And during the switch on, there were no responses observed in this patient. The extreme electrodes were switched off, and the post switch on mapping session, the neural responses were not present at all. To reduce stimulation rate and increasing the pulse width, we did it, and the child did not show any awareness of sounds. So during the course of therapy, they showed better responses for pure tones as compared to speech sounds, and the child had to be trained for awareness and conditioning using pure tones. So after training, the child should showed conditioned responses to sounds after 6 months of therapy, and after 2 years, child started imitating sounds with auditory oral approach. Child communicates using the sounds, but child is attending the school, but teachers have to be told his communication, special needs for communication. So coming to this, whether we should use the full band or in a common cavity, or better to use a full band electrode rather than the half band or small flexible slim electrodes. So in malformations like common cavity, but the NYU Institute people have found out whether they use the straight electrodes, slim electrodes, or whether they use the full band electrode or the half band. They have not found any difference in the performance of these patients. So they would advise actually to discuss the post-operative X-ray with the audiologist and tell them to whatever electrodes are there in the anterior wall of the cavity to be more activated. And if required, the one in the posterior wall, they will be producing these non-auditory stimulations may be made to switch off to have a better results. So now it is also advised that video fluoroscopy based imaging for insertion of electrode array in malformed cases, typically the common cavity, is very good, and you will be able to do a proper insertions and seeing that your electrodes lie in the anterior part of the cavity. And it is also most important to note that all these malformation cases take several months to notice the actual outcome after the surgery and the therapy. So this is another hypoplastic cochlears. hypoplastic cochlea type 3 and type 4. And in these cases, the audiological findings can be very much variable. But when there is a severe to profound degree of hearing loss with a normal cochlear nerve, cochlear implant will be an option in treating these patients. Of course, if there is a profound loss with a cochlear nerve deficiency, he will be a candidate for auditory brainstem implant. So in these cases, it will be difficult to identify the promontory or the round window in a hypoplastic cochlea sometimes. So one may require to do an empty tympanotomy. And another possibility is CS2, there is a possibility of a CSF gusher. So in such cases, better to use form 19 electrode of the metal sometime with the stopper, so which can be used to stop the CSF leak once the electrode array is inserted inside. Because this cochlear hypoplasia with a smaller turns and a scala, it's better to select a shorter and thinner electrodes compared to the longer and thicker electrodes. And of course, the pre-curved electrode also to be avoided. Cochlear nerve deficiency is also common in these cochlear hypoplasias. So one can do a possibility of doing a cochlear implantation on the better side with a contralateral ABI if there is a limited hearing benefit with the CI. So in which case one need to do a cochlear implantation on the better side early, in the sense as early as maybe within the first year, and then you have some time for a year or so and plan the second year ABI if required by a month, by 18 months or 1 year to have a better outcomes. So children with 2 to 3 years of age, so Dr. Sanaroglu advises in these cases a one-sided CI and a contralateral ABI, which can be done simultaneously. We don't have experience with that. Coming to the incomplete partitions, the cochlea is located in the usual side anterolateral to the internal aortic canal, whereas it lacks the modulus in incomplete partition type 1. And they will also have a dilated vestibule. So in IP1, there is again a severe to profound degree of hearing loss. Most of the time, they are always candidates for CI. So the straight electrode is preferred in these rather than the modular hugging electrodes. Modular hugging electrode should not be used as there is no modulus at all, and it is a single cavity like thing. And a conical stopper used to stop the CSF leakage around the electrode. This is most important because one should not leave the OT without stopping the CSF leakage from the cochleostomy site in these cases. So if there is a cochlear nerve aplasia associated with IP1, then they are not candidates for CI. ABI will be indicated in such cases. And of course, the classical Mondini deformity cases associated with enlarged vestibular aqueduct, they are again the cases for CSF gushers. So they may have again various different types of audiometric findings. And usually it will be a progressive hearing loss, and sometimes they also can have an airborne gap, particularly in the low frequencies. This is because of the third window effect, because of enlarged vestibular aqueduct, which is associated with these cases. So usually progression of hearing loss in these cases makes them to become a candidate for cochlear implantation. So when they need cochlear implantation in these cases, again, some electrode like a shorter electrode like form 24, which also has got a stopper, can be used for stopping the gusher and inserting this basal turn of the cochlea. One can also use a straight electrode with a temporal fascia washer, something like take a 1.5 by 1.5 millimeter temporal fascia or a periosteum, make a central hole in that, and through which you can thread the electrode and keep the fascia just immediately after the electrodes are over at the proximal to the electrodes, and insert the electrode, and at the end of the complete insertion, you can use the same tissue fascia to plug the cochleostomy. And one must keep in mind that stepidotomy should not be performed even if there is an airborne gap in these cases, because this airborne gap is not because of fixation of the stapes, because it is due to the third window effect. So you can lead with a severe gushers in this case if you attempt stepidotomy. As all these IP2 cases will have a good cochlear nerve, ABI is not indicated, so please keep in mind. This is one of a patient where there was a gusher. the facial canal, and I'm just drilling anterior-inferior to the cochlear round window. You can see the moment I drilled, there was a gush of CSF which is coming. But of course, with the head end elevation and hyperventilation and giving steroids, we could lower and giving time for the gusher to come down and stop. So after that, we did insertion. In this case, I have used the cochlear nucleus straight array. In this case, there is a big cochleostomy and there is a sufficient space all around, which I plugged with a periosteal tissue. This was one of my earlier videos where I had not made this portion of this temporal fascia washer. So one can do this. Either there are two ways. Either you have a bigger cochleostomy and put the electrode array and plug. You have a sufficient space to plug the connective tissue, or you have an exact size cochleostomy so that insertion of your electrode itself will stop the leak once it snugly fits into the cochleostomy. So one patient of bilateral profound sensory hearing loss with a right-aided response is better than the left, was fitted with the hearing aids and attended AVT sessions, and there was they showed better responses on the right side than the left side. But this child also had multiple issues like laryngomalacia, deglutition difficulties, and other feeding gastrostomy and things like that. So this was the CT and MRI pictures. On the right side, you could see a thin nerve going to this anomalous cochlea, whereas on the left side, it was very, very doubtful. So we decided to do an implantation on the right side in this particular case. But there was a lot of bony overhang, which operculum, which we had removed to expose, but we could get a good view of the round window. In this case, I did a round window insertion here. I'm just puncturing the round window. You can see the perilymph coming out. And here we use the advanced Bionics 1J electrode. This case, with the introducer, I'm able to push. To our surprise, the whole 16 electrodes went in, and we were able to plug it nicely. But on the table, when we did the seal the cochleostomy with the periosteal tissue, but when we did the intra-op testing, so during the insertion, impedances were normal, but intraoperative neural responses were obtained at a very high level and in only one set out of the 4 sets for advanced Bionics. So this was a post-op X-ray showing this electrode in the basal turn of the cochlea. But there is, in the switch on, there was a definitely behavioral response to speech sounds were observed. Response were definitely lower and better than the predicted levels. Few days after switch on, the neural response is present in 3 sets, and child showed awareness of the sounds, few post-op switch on, and conditioned responses. Child was decannulated and consistent responses to sounds after 2.5 months. It started using vocalization for communication and showed good improvement in communication skills. And now she is better even with distance hearing and going to a normal school. And this, of course, incomplete partition type 3, where one should be very careful when you are doing the insertion. Again, there is no modulus, no modular hugging electrodes, straight electrodes. One should do it under the image guided control, or take the X-ray after your insertion to make sure that your electrode has not gone into the internal auditory canal. Again, these are the direct communication with the internal auditory canal. They are known for CSF gushers. So without ascertaining the position of the electrode in the cochlea, one should not leave the wood. And cochlear nerve abnormalities, again, when there is a normal hypoplastic cochlear nerve or a hypoplastic cochlear vestibular nerve, these can be considered for cochlear implantation after windowing the MRI scans to look for the possibility of a thin nerve. So in this case, as you can see, there is a hypoplastic cochlear nerve. So CI can be considered prior to ABI in these children, especially when the auditory responses are present. We had a case like that. The child had a bilateral profound sensory hearing loss. CT was showing a double internal auditory canal, but MRI was showing only a normal cochlea and one nerve bundle in the internal auditory canal. This was the unaided audiogram, and this was the aided audiogram, where you could see a good response on the left side still, but right side also there was a little better, but it's still below the speech banana. So in this case, we also did the link sound tests and early speech perception test, which showed definitely a better responses on the left side. Monaural left side responses were better. And we ultimately did an electric ABR in this case. As you can see here, on the right side, there is a good wave 5 formation. It was appearing early compared to the left side. Depending on all these tests, then we decided to do an implantation on the right side. Here I'm again doing a cochleostomy here. So in this case, we did a soft surgery technique. So where you drill the cochleostomy till you visualize the endosteum. So you can see this is the endosteum. So once we reach the endosteum, then it is opened with a pick, stepidotomy pick, which we use. And you can see like a lid, it is opening and the perilymph is gushing out. So once you open that, you use little Elon at that time, and that did the insertion. In this case, I use the contour advanced electrode from Cochlear. Up to the first marker, it is introduced first, and then the stillet is held with a Julius forceps from the left hand, and the electrode array is advanced off the stillet, and then the cochleostomy was sealed. So after 10 months post-implantation, because there was a technical failure of the nucleus 5 implant first, and then because of the hermetic issues, this child was re-implanted with, as I said, contour advanced electrode. And she has been attending normal school. She has done good with the speech and language development, and she has upgraded her processor recently to Nucleus 7. So in case of deficient cochlea now, a good quality MRI resolution is very, very important. And windowing is more important critically to assess the presence or absence of the acoustic nerve rather than just depending on the radiologist report. So early implantation really matters in these cases. So implant within 6 months to 1 year of deficient nerve is assessed, because if deemed necessary for ABI, ABI can be planned after 18 months or so. So this again depends on whether the patient is getting a government funding or a self-funding. So the question is TTABR again essential for in deficient nerve cases? The reply is both yes and no. However, because it is not very sure, because even the NYU Center have studied these cases, whether it is yes or no, they go ahead with the CIT, because they have found when there is no also the responses and the outcomes what they have seen are sometimes surprising. So meningitis, post-meningitic hearing loss, then 80% of these patients develop labyrinthitis ossificans. So depth gauge is a must when you're treating with the obliterated cochlea. And usually in these cases, we use a contour advanced electrode with the stillet in situ and by using a non-AOS technique, or one can use a double array. So complete ossified cochlea drill out procedure has to be done. But however, the results of drill out procedures are not very good. So better to do as early as possible. And if required, sometimes if you are in delay in getting the funds, so one can do a cochlear stenting by leaving the dummy electrode or the depth gauge in these cases. Only when there is no response with the CI, then ABI can be considered in ossified cochlea. So I'm just going to show one double array. The patient of 11-year-old boy who had a meningitis 1 year back and came to us with a bilateral profound degree of hearing loss. His parents had tried the hearing aid and not finding relief. He underwent left cochlear implantation with a double array. So this is the CT findings what he had on this. And this was a video which is showing here. We did the first cochleostomy to enter the basal turn. And after that, we removed the incus buttress and removed the incus also to do the second cochleostomy. So second cochleostomy is usually done just anterior to the round oval window and just below the processus cochleariformis. When you are drilling the second cochleostomy, one should drill it more vertically, because rather than if you direct your burr more anteriorly, just anterior to that, you will have the carotid canal. So one might land up with a fatality. So here we are double array, we are inserted first in the second. So here it can either go towards the apex or towards the basal turn. So it has gone here. We were able to put 8 arrays in the apical turn, and in the basal turn, the second basal array was put where we were able to put again 7. So out of the 22 electrodes, totally we were able to put 15 electrodes in this case. So, and this boy did extremely well, and he finished his graduation and he has been working now. So this is how it looks like a double array. This is the ground electrode, and this is a basal array with 11 electrode, and the apical array with another 11 electrode. This is one other patient who didn't, it's again a meningitis patient, post-meningitic hearing loss at the age of 4 years, but we detected immediately, and within the first month, after first month, in the second month only, we did the implantation bilaterally without waiting for any fibrosis to develop. So that is how these people develop, will not lose their much hearing and speech, they will do very well. Coming to the bilateral implantation, this was the first cochlear bilateral implantation in the country, which I did in 2007. So bilateral implantation has got its own merits. So with this, the patients will feel more confident because of better sound localization and being more aware of this sound environment. They feel more connected because of better speech understanding in noise, and they are socially more interactive in conversations. And the patients will be more relaxed because the listening becomes much easier. They enjoy very balanced sound from both the ears, and the learning becomes very incidental. And we are also confident that the better ear has been implanted. This one or two just videos I'm just showing for the bilateral implanted child. This child was implanted at 14 months. This is 5 months post EVT. And then you will see when she's 1.5 years old. This is that. You are doing a Bharatanatyam dance. All these children were implanted simultaneously. This girl was implanted sequentially. Okay, this is last my speech.
Hi, I am Tanmay from Bangalore. I am here to tell you my journey from a baby now who could not hear or talk anything to the most talkative student in the class. Yes, I am studying in class 8 in a normal school and I love talking a lot. As you can see, I was implanted with Cochlear when I was age 2. My mother took me to speech.
So to keep in mind is the right CI candidate gets the immense benefits in hearing outcomes and the quality of life. A multidisciplinary team is the key for assessment as well as managing these children with profound degree of hearing loss as well as the adults. And early referral and implantation is crucial for good outcomes. And counseling the family for realistic expectations and their willingness to enroll in the rehabilitation program goes a long way in getting good outcomes in these cochlear implantation. Thank you very much for your patient listening. I think we are done with time. Mohnish?
Hello.
Yeah. Can you
Yeah,
hear
can
me?
you hear me, sir? Wonderful talk, sir. I mean, it was something which we all wanted to hear to start off, especially dealing with the advanced aspects of candidacy as well. Now, there are a few questions, in fact, a couple of them. Let me just take one of them right now, because other we might actually discuss during the panel itself. Right. So Dr. Ramesh Rohiwal from Aurangabad, sir, is asking, is there any role of IV mannitol during gusher?
I don't think so. Mannitol may not be shrinking the brain. So only I don't think it has got any role. We don't use it. Only we do other manures, what I told.
Yeah. So I think that's something which almost everyone will now follow. I was one who started off, using mannitol when we were there, and now we don't use mannitol at all. Let me take a second question as well. Dr. Arun Srinivasan from Patna. He has asked if you are experienced with ANSD.
Till now, I think I have done not many ANSDs, but five, I think, five ANSDs I must have done. In these cases, all the time, I think we have gone ahead and done the electric ABR. In these cases, when we have found a good response on the AVR, then only we have done the performations, and these children have done quite well, very well, I could say.
Okay. So that's good to hear. If Dr. Vijay allows me, I think let's go off to the panel discussions, and as and when we have questions, maybe you can take up those questions and we go ahead with discussing those. So so good evening once again, everyone. And what we're going to do now is, after this wonderful talk, we are going to have a panel discussion with various stalwarts from across the country, and that's going to be about various difficult situations in cochlear implants. And to discuss these, we have these 5 eminent panelists. Dr. Amit Kishore, sir, has been instrumental for various centers, including myself. We started a cochlear implant program under him, and he is presently working in Apollo Hospital, New Delhi. Welcome, sir. Dr. Kranti Bhavna, a very good friend and heading the department at AIIMS Patna. It is probably, she's going to be instrumental for this panel because she's the only one who's doing Varia among all of us. So it will be good to hear her, inputs on that aspect of cochlear implants. And Dr. Mathu Kumar, sir, is working in Chennai in Madras Medical College, and it's going to be a good representation from the southern part of the country, and which harbors many great people from cochlear implant field. Dr. Preetham, another dear friend of mine, working at AIIMS Bhubaneswar, and is the professor of ENT. And sir, so we will have more. Ask for your suggestions at the end, maybe as a final discussion for any question which is controversial and not being in the same field. So we have these 5 people. It's wonderful to panel discussion. We come in front of them, and we will be taking these 5 panelists. And let me just, maybe we can start with one of you, and then you can add in if you have something different to add on. So
We can't hear you. Audio is cut.
hello.
Yeah.
Sorry, it's had a bad connection here probably. So this is the first case which we are going to discuss. Now let me start with Dr. Amit Kishore sir here. This particular kid is a 1-year-old child with no particular risk factors, right? The father being a shopkeeper, mother being a housewife. The okay. No family history of hearing loss. Now, when OP screening was done at 1 month of age, came out to be referred for this kind of situation now.
Mohnish, your voice is breaking.
Yeah.
Your audio is not very.
Yeah, you may switch off your video and try.
Yeah, you can take away the virtual background. That sometimes helps.
Virtual background and video also, if because now your screen is hang.
Dr. Amit, I think you can discuss till Dr. Mohnish joins
yeah,
us.
I think I've got
Yeah,
good
you
evening,
are.
everybody. Great, thanks for having me on the panel. So I think the concept here is about early diagnosis for hearing impairment. So in a situation, it depends on what screening protocol you might have, whether you have a primary OE screen and a second OE screen if the first comes back as a refer, or if you have an OE and automated ABR screening. So it does depend on the center that you're in, and there are both these types of protocols that are possible. So the point is that at the age of 1 month, if the child refers on the OA screen 1 month, you must repeat that screening at the same time within a few days or a week. You could use a second OE, or if you have access to automated ABR, then you would do that at 1 month. Now, if you have a refer on both these, so you have two refers or you don't have a good response, then in our situation, we would do a comprehensive, a full hearing assessment at the age of 3 months, which is, both evoked potentials, which is ABR's diagnostic otoacoustic emissions, and behavioral observation, audiometry, and impedance with reflexes. So it's not just about doing ABRs or ASSRs, which is a very common practice. A comprehensive hearing assessment should be done, because you have to follow the cross-check principle to cross-check the findings on evoked potentials, preferably not just click ABRs, but even tone burst ABRs. So if you really want to be very, very thorough, you need to do click ABRs, which is centered about 2K. You should do tone bursts at 5 and 1K. Of course, ASSRs will follow. You need to do impedance with reflexes and corroborate that with behavioral observation ometry. You should do all that at the age of 3 months. That's what we would follow.
So would that mean that, at 1 month, if there is a refer OE, you won't go ahead with the ABR at 1 month of age?
So, like I said, it depends on your protocol. So either you have to have two screening tests. You either have the first OE and the second OE. But if you have access to automated ABR, then in an ideal situation, you would do an OE and then also an automated ABR at 1 month.
Okay, fine. Anybody
So that's
else?
what we would do.
Would everyone agree with this kind of protocol, or you differ in your protocols?
Yes.
We would agree.
Yes, sir, we would agree.
Yeah.
Perfect. So let me just share what this is what Siji actually was trying to bring out, and quite a few people who worked on it. Rashmi Deshpande was one of them as an audiologist who was actually an integral part of this. And what this actually talks about is, if you have no risk factors and OE at birth or 1 month comes out to be refer, then it has to be repeated within the 1 month of the previous OE you repeated. If it still comes refer, then you go ahead with ABR maximum by 3 months of age. That's exactly what Amit Kishore was referring to. And if it however has risk factors, then you land up with doing OE and ABR both at 1 month of age, and follow up with both OE and ABRs, because that's where the screening would actually, protocols would change depending on the absence and presence of risk factors. Now, Preetham, let's assume this particular patient, now grows up, is 9 months of age when the child comes back to you again. By this time, he also had an history of one episode of high fever with vomiting and query seizures at 7 months of age, right? OE was a refer, and ABR which the patient has brought to you is 6 months of age, did not. Next, hearing aid, CI or radiology, what do you want to do here? You need to unmute.
Yeah. So what I understand is that there has been a history of high fever with vomiting, which obviously raises an alarm that are we dealing with a case of meningitis which has occurred. So that obviously will let me know that I might be dealing with a malformed cochlea. So radiological evaluation is something which is a top priority or a high priority for me, based on which then I will go forth and decide what I will do with this child, which includes whether I'm looking at a malformed cochlea and also the status of the nerve. I think we lost Dr. Mohnish there. So what I'm trying basically do is when somebody has recurrent meningitis, then I would be looking at a probable IP1 deformity or a CH2 deformity. So if something of that sort is expected, then we also had to look at the nerve, and then that will basically guide us. How do we go further? Because if the nerve is there, then yes, we would look at a probable CI, and if the nerve is absent, then the other options come in.
Mohnish,
Was
audio is problem.
Yeah, I think, sir, any of the others also till Dr. Mohnish joins in can add on anything else that you would do, sir.
No, I
Medikeri,
agree.
sir, or
I agree with Preetham. I think radiological evaluation take the priority in this case. And depending upon the radiological findings, then we'll further decide.
yeah, sir. So basically, just for the keep the discussion moving
Somehow
forward.
I
Dr.
can hear
Mohnish.
you on.
Okay, so your voice is cracking. Maybe you can just try taking off the virtual background or.
But I think the point that Preetham has made and Dr. Medikeri agrees is that unlike very traditional old school of hearing aid trial, if there is a hearing loss and then you see what happens, I think we have to move to imaging very early on.
Yes.
Because valuable time gets lost if we are sitting on hearing aid trials and then find out many months later that the child has a deformity or an abnormality or possibly meningitis, post-meningitic cochlear fibrosis. So the key is that if we detect a significant hearing impairment, then early imaging with an MRI, because then you don't have the issues with radiation in a small baby. So you can move first with an MRI right away. You get the situation of the cochlear anatomy, get the situation with the hyperplastic or nerve or whatever the status is. You can look up, you can identify any evidence of fibrosis or ossification. So that should be the take-home message.
Correct.
Perfect. Am I audible now?
Now, yeah.
Yes, sir.
Yeah, you're back.
Thank you. Yeah, so I think the panel already said what was important here. Now let's assume the patient, we believe that the patient here had meningitis and therefore radiology becomes very important. Now, if however, let's assume this patient was in fact later on found to have only food poisoning and febrile seizures instead of meningitis, and the ABR, which the child has now grown to 3 years, the child has still not underwent a cochlear implantation. The right side, there are no waves. The left side, now there are a few waves which are identified with the BERA, which was done at your particular center. The patient has been using hearing aid for last 2 years. The psychological evaluation goes on to show moderate to severe ADHD. Right, Dr. Muthukumar sir, what's your take, especially with this kind, 3 years, moderate to severe ADHD, but a regular hearing aid user? What's your take on these kind of patients?
Yeah, since on the right side there is no wave, on the left wave there is a definitely identifiable wave at 80 dB. So still we can go on with the psychological therapy as well as the speech therapy, and whether we can wait for the improvement and then we can decide upon.
And how long do you want to wait for an ADHD 3-year-old child? And do you really recommend cochlear implants for them?
Since the response is there, and based on if the child is parents and the child, they come for regular follow-up another year or so, and then if it is not improving, then since in our state we have the implant program till 5 years of age, I will give a year or so for another try, and if it is not showing tangible results, then we can go for implant.
Now,
Mohnish, what are the radiological findings in this case?
Radiology is normal, sir. There is no problem, right? It's good.
Yeah.
Good cochlear, good nerves. Now, my issue here remains is how many of us would really, all the panelists for that matter, would go ahead and do a cochlear implant in a child with moderate to severe ADHD? Anybody who wants to take that?
I would not necessarily deprive a child with ADHD with hearing a cochlear implant. Of course, it does require an experienced psychologist or pediatric neurologist to opine on that. But I would not necessarily, this would not be a contraindication for me. We have to discuss it, of course, with the parents, because we also have to keep in mind that is the other thing that I've noticed is that, okay, you have a left wave. So first of all, again, I would reiterate that we don't just rely on ABRs. We would want to corroborate that with age appropriate responses, conditioned responses. So if he's 3 years old, then he would be able to do play audiometry. Because if you have hearing, if the ABR waves are available at 80 dB, this means the hearing is probably better than 60 or 70 dB. So I would be concerned as to why there is not much speech development if he's been using hearing aid for the last 2 years with at least one hearing sense. So I would take that all into consideration, but I would not necessarily deprive that child with a cochlear implant.
So
on the other side
would be that even if there is an ADHD, a cochlear implant is not contraindicated, and in fact, you may just counsel and take a proper consent regarding that, and still go ahead with a cochlear implant. Now we had a similar question, which was being asked.
Mohnish sir, one important point which I want to add is that having seen so many children, and post the failure of cochlear implantation, especially there is trauma causing device failure, sir. History of trauma causing device failure. So I would also take that point into consideration, how the parents are managing the child, the attention of the parents towards the child. That's also important because I have a child who has been operated just 2 weeks later. After switch on, the child is brought with a device failure, sir, with history of injury against the table,
that's
against the table.
So I do agree, especially with ADHD kids, we all know they can be difficult to handle, and
that's a point. Good point.
It's important to take care and especially counsel regarding that. Now, Kranti, if we may have your word on this, let's if what changes, as we were discussing initially also, is if let's say the OE in this particular patient came out to be pass, right, and ABR is still similar. So how do you handle this kind of a patient now?
So then this becomes a bit confusing. You have a OE pass and there are no waves on the right hand. But as sir was telling, now again, this is now the indication for doing a CI in such cases will be, I think, so the results might not be very great, because then we're looking at not having a child with moderate ADHD, but might be having some kind of dyssynchrony as well. So another added, so there is one negative point already, 1 or 2 negative points, and we're adding the third. Now it all depends. We work in government setups, but obviously even in government setups or in private setup, it becomes important what is the parent expecting out of their kid. The kid is not able to participate in any of these discussions. So what is the expectation of the, and we all know that implanting in auditory dyssynchrony along with these kind of challenges is going to be really, really very challenging. So if you add that kind of picture, then I would really be a bit, reserved in implant.
Let's remove ADHD from this scenario. If it were a pure ANSD kind of a thing, now how do you manage this kind of a patient?
Yeah, so as far as our center experience with ANSD is concerned, I should be very frank, I have done only one as of now, and she has been switched on a few weeks back, but actually now stable. We are just beginning her therapy. So experience is one, but we know the literature, how it goes with ANSD, and it depends which kind of, So ANSD will respond in various manners. So adult ANSD patients will have normal hearing versus profound hearing loss. In this case, you have ANSD with profound hearing loss. People have had good results with it as well, but people have had bad results as well. So this is still a matter of research, and there are so many other, if you discuss DNA.
My issue with this also has been that, at times my audiologists have told me that the child is actually doing pretty well with the hearing aids and not to go ahead with implant. Now, does somebody add on that aspect? Dr. Amit Kishore, sir, yeah, please.
Yeah, so Mohnish, a few things here. The management of ANSD has to be tailored to the auditory response and the performance of the child with other devices. That's the first thing. So not every ANSD child is going to behave in the same way. That's one thing to remember. Secondly, of course, you cannot rely on ABRs for thresholds because you will not get ABR. So here it's a bit confusing. The right side I can understand. The left side, you have a wave at 80 dB and pass on OE, that doesn't match. But of course, we are assuming that this is ANSD, so we would probably not get waves on either side. Having said that, yes, you have to rely on behavioral observation or condition audiometry. The levels will fluctuate. We have a fair experience with a variety of kids with ANSD. So we would always look at the responses with hearing aids and closely monitor them when they're on the habilitation program. And in that situation, if these, depending on the behavioral responses, depending on the speech and language development and auditory responses to hearing aids, we will decide. Some children will do well with hearing aids. They may need assistive listening devices. One of the problems in ANSD is noise. So they may need FM systems or Rogers systems and things like that. And if children are plateauing, then we would look at an option of a CI, of course.
Let me try to put it forward as a simple question. In your experience, how many of your ANSD kids with a profound hearing loss have landed up with a cochlear implant?
Okay, so if you are, so when you are saying profound hearing loss, we are talking about profound hearing loss as diagnosed on conditioned audiometry. You cannot rely, I'm repeating, you cannot rely on the ABR. So if they're profound hearing loss, then they all go for, then they are straight cochlear implant candidates, because you have a hearing loss which is profound or severe to profound with ANSD. So they, almost all of them will go for a cochlear implant. They don't have another option in any case because they are not going to do well with it.
Severe to profound hearing loss within ANSD, they all land up with the CI. Now
they all land up with the CI with caution, with the disclaimer and counseling of the family that the results can be unpredictable. We have used transtympanic EABR in some of these kids. We have tried even cortical responses. We've done cortical evoked responses on some of the older children.
Does it help? Does it help?
Well, if we get, we see, it seems to be like Dr. Medikeri has already said. I think it's more reassuring if you get cortical responses and responses on EABRs. If you don't, it doesn't mean that we don't offer them, but then the level of caution goes up. And of course, they have to have normal MRIs. So,
and overall, are you happy with the results? Of
yes. Okay. Most of our children with ANSD who have had cochlear implant are doing well. Adult ANSD is a different thing. We won't.
I think Dr. Medikeri sir also mentioned the same. Preetham, you wanted to say something on this?
So what I'll just reiterate something. So first and foremost, what I've seen is when these kids go for hearing aid rehab, if the audiologist is not very well versed, they tend to use the normal costly hearing aids, and that's obviously not going to work in these children. You need to use those specific single channel or double channel implant or double channel hearing aids and then look for the responses, because that's when they will have meaningful responses. And and again, these ABRs and the evaluation should be able to tell us whether we are dealing with a presynaptic ANSDs or postsynaptic ANSDs. And in children, majority wise, you would have presynaptic, and then definitely we expect a decent sort of a result when we do an implants in them. But if you take adults, then it's usually postsynaptic, and then the results are very, very much reserved, and you should be very, very careful with regards to that. So yeah, the audiologist should be very, very careful in selecting the appropriate hearing aid, because the Cochlear and the multi-channel hearing aids would not work in them.
Yeah, so something similar, right? When we talk about the literature also, they actually believe that ANSD does help. The language may lag behind sometimes, but it's overall a significant improvement noted. And something similar has been published in various literature. They also mention that a few percentage would actually land up, if you're talking about ADHDs, a few particular patient number may land up being non-users. So that's a part of the ADHD spectrum, which again needs to be counseled well. Now, the patient is now 6 years, still not gotten cochlear implant. The ADHD has improved with various kind of therapies possible. Now, a simple question to all of you, right? What's the eldest prelingual patient you have operated upon? Okay, come with an age and no reasons at all. Amit Kishore sir.
I think we have done maybe 8 or 9 year old also, very, very rarely, very few, but that if you look at a single number, yeah.
Yeah, that's a 9 year. Medikeri sir.
Prelingual, but not with a good, I've done almost, I've got 11-year-old girl, one girl I've done.
11, right. Kranti.
Yeah, okay.
Let's just keep it to figures right here.
Yeah.
This boy who was using a hearing aid, he was a prelingual, 13 years old.
13.
That
7.5.
Good. And Dr. Muthukumar sir.
Sir, we have done a child, a girl child for about 11 years, not for the sake of any improvement, only for the sake of hearing awareness. The child was so beautiful for the sake of self-protection and hearing sound awareness.
Yeah.
The mother was pleading to us. So under the program, we have to do it.
So do you think funding is got a role to play in this? What happens to us is if the patient comes to you, the parents come to you that they have enough money, and they would want to get it done. And this is one of the particular things which I hear is even if there is a 10% benefit, we would get it. Now, would you actually operate on, let's assume, a 12-year-old child with this kind of a scenario? If do you believe in the concept of telling them about limited expectations, environmental awareness, and then still going ahead with a cochlear implant?
Yeah.
Whom of you would actually do it? Forget it's a private or a government fund. Would you operate on such a patient? Anybody would? No.
Most of the time we are refusing them.
Yeah, so try to refuse on them. Majority of times you would try not to, make them. I would actually always add if, whatever you get probably would be a bonus at this particular point of age rather than expecting anything. Now, AIMS New Delhi recently did a study on this, and that was a CG-RGP project on older prelinguals, getting a cochlear implant done. This is one of those, papers written which includes Tom Rowland and Susan Walsman about the hearing results or the results of cochlear implant per se in older prelinguals. And that's something which is, in fact, if you look at CGHS, they would actually allow till 16 years. In their papers, they mention 16 years, till the 16 years, they allow prelinguals to be operated upon. And that's something which, luckily majority of states have now gone down with, especially the government funding, which we need to really consider. Okay, now we go to surgical scenarios, right? And, when you're operating on this particular patient, which we discussed upon, Kranti, this looks like a Varia technique in picture. Now, this can be in any technique. This could be posterior tympanotomy, and we'll discuss it, the posterior tympanotomy surgeons. But if there is a breach in annulus or when you're lifting, there's a tear in the flap, what do you do?
basically, kind of scenario can occur, but now it's very rare with better techniques which we are doing. But if this occurs, a very nice layer of bone pate followed by a temporalis fascia, and you put the flap back. Most of the cases, no issue. That's
No, I have heard quite a few surgeons doing the Varia technique that they would, prophylactically also put a temporalis fascia graft. Do you really practice that?
That in all my cases, even if we don't encounter all these EAC breaches, but even without that, I use a layer of bone pate and a layer of temporalis fascia and put my TM flap back. Last few of the cases, I have changed the incision completely. I do not do any metotomy anymore. I just raise the flap in one go, and so there is no canal incision at all. So that further improve the healing aspect of the whole procedure. But yes, bone pate is fascia good enough to solve it.
Yeah, it usually works out, right? And for the posterior tympanotomy, we can actually have, when extending the posterior tympanotomy, you may actually have a breach in the annulus, right? I have experienced them in my initial cases. Kranti, you want to add something?
One more thing, a word of caution: people should never use a bone wax. Never use bone wax anywhere near. Or I think I avoid totally in my.
Absolutely, yes. So now that's a various thing, right? You would have when you're elevating the flap, it gets torn, or you have a breach in the EAC. Posterior tympanotomy, again, there may not be any flap, but when you're extending it anteriorly, you may actually damage the annulus. And that's why I always tell my residents, even when they are painting, they should instill betadine inside the external auditory canal, so that I would see any kind of minor trauma in the EAC, so the betadine leaks inside the field. So that actually tells me that. But if that happens, Preetham, how do you kind of deal with it? Similar manner what Kranti mentioned, or do you leave it as such, considering traumatic perforations may heal?
No, I would just agree with Dr. Kranti. I would just go on and do a underlay, or I'll just put a fascia and come out, and I should be okay with that. And obviously, if there is a canal wall, EAC canal which has been injured, then bone patty and put a fascia over it. And
I think the major point here is don't overlook this thing. If there's a small breach, take care of it that particular point itself, because that's something which can later on create havocs, right? The next thing is, then let me go to Dr. Muthu Kumar for that. One of your friends was doing it, and this is the issue which you had. The facial nerve, that's a posterior tympanotomy which has been done, and there's a facial nerve here which has got exposed. You've still not seen the round window. Now, how do you go about handling this kind of a situation? You need to locate the round window. You need to do a cochleostomy, insert your electrodes. How do you actually handle all this?
So now I would, if the facial nerve is exposed, I would try to extend the posterior tympanotomy both superiorly at the cost of the incudal strut, as well as inferiorly also up to the caudofacial angle to the fullest extent, so that the shaft of the burr never collides with the rubs with the exposed facial nerve, so that I have enough angulation to introduce the burr as well as, so that I don't include the facial nerve, and with further thinning of the posterior canal wall, the shadow doesn't obscure the view through the posterior tympanotomy, so that I can locate the round.
Perfect. So that would mean extending it. Do you mean to say that you would actually remove the incus bar? I mean, I didn't get that point.
No. I will try to save the minimum incus bar, but I would because the persons the amount of the incus bar minimum of a millimeter or so. Some people they in the beginning stage itself they will have a wide incus bar, so we can expand it at the expense of the incus.
And you thin out the posterior canal wall, which you mentioned correctly. Anybody else now wants to add on to these tips? Preetham, Dr. Medikeri, Dr. Amit Kishore, if we want to add on to any tips. Yes, sir.
Of course, as you mentioned, thinning of the posterior canal wall to the maximum without causing any buttonhole in the bony canal. Very important. Then, rather than more at the incus buttress, I would definitely love to extend the posterior tympanotomy inferiorly till the caudofacial angle and change your visual axis of the microscope and see whether you are able to see. If I'm able to see even a glimpse, an elliptical lower lip of the round window, that is good enough for me. Still, I will take that and go ahead and do the posterior cochleostomy in relation to that, and then go ahead with the implantation. Otherwise, the other very, very difficult situation, absolutely you are not able to see round window at all. Is there another two options? One is either to mobilize the posterior canal bone itself and pushing it forward and visualizing it, or else I may have to do an anterior tympanotomy and visualize it. Go ahead and do the cochleostomy.
Okay, so let me just revise the points which are there. As Dr. Muthu,
I would like to impress upon is that, especially we are doing for the single-sided implantation, we always do on the right side, right here. So I would shift the, I will handle the burr with my left hand, so that my right thumb and the index finger doesn't obstruct the view, so that an added exposure I'm getting. So that is also one important technique which I follow. You are dealing with my left hand.
Stay away. Yeah, so stay away from the area of exposure of facial nerve, so you don't actually kind of damage. So these are a few tips again, as we just discussed. Thin EAC wall fracture if needed. Angled handpiece would especially be useful to get that angulation in. The long taper burrs, if you could see this, this is the short taper and this is the long taper burr. So you would be happier to use a long taper which has a narrower, part of the shaft going inside the posterior anatomy. Curved burrs are now available. So a few companies have these curved burrs which would actually be able to, take care of the bulge because of the exposed facial nerve. And when you're closing, do remember to place soft tissues between the facial nerve and the electrode array, right? You don't want it to be constantly touching the electrode array later on. Okay, now, Dr. Amit Ashok, you have blue ear edematous mucosa. Can you abandon the surgery? If you continue.
Okay, your voice is breaking, but I again presume what you want to ask. No, we would of course not abandon the surgery. In this situation, it's a matter of using some gel foam with some adrenaline to decongest the middle ear, leave it there for a few minutes, and almost always all that congested mucosa will shrink. And using then you'll get your landmarks and of course getting good access as we just discussed with the posterior tympanotomy. So it's not an issue. Just be patient and use some local decongestant. That's what I would do.
Okay. And no abandoning, right? Nobody would abandon this surgery.
No.
Okay. Now,
Dr. Medikeri wanted to say something.
Yeah, another.
Yes, sir.
Because we'll also look at the all the mastoid hair cells. If there are a lot of any granulations or anything like that, and a lot of blue or hypertrophied mucosa, I usually try to do a regular mastoidectomy in these cases, unlike the mastoidectomy for cochlear implant, meaning over edges.
Yeah.
Apart from whatever the points he said for decongesting the middle of mucosa and identifying.
Now has anybody done a cochlear implant with a grommet in situ? Sorry. Okay, so I think it's a bad network. Can you hear me?
Yes, we can hear you, Dr.
Okay, sorry. So has anybody done a cochlear implant with a grommet in situ, with a ventilation tube inside?
Sir,
yeah, I have. It's been a while. I have. I'll very quickly tell you that how the thought process had changed and since I was first exposed to cochlear implants. So in the last maybe 20 years when we were first doing them in the UK, the process was that you treat the OME with a grommet, you wait for the grommet to come out, or you would remove it and then wait for that perforation to close and then do a cochlear implant. So that was the philosophy maybe 15, 20 years ago. But over time, if children did have a grommet, there was no hesitation to putting a cochlear implant, even with a grommet in situ. So we were not going and we're just leaving that grommet and letting it come out on its own. So that was a change in policy. I have not been in a situation where I've put a grommet at the time of cochlear implant, but if there was a grommet in place, I would not remove it or I would not hesitate to do a CI.
And you have done cochlear implants with grommet in situ?
I have, yeah, but that was quite some time back. I have not been in that situation for some time.
Yeah, I've never done it one, and I would actually still be pretty worrisome about using it. But yeah, people have done it. Literature shows that it's pretty safe, and people have gone ahead, done it, and never abandoned the surgery. And as we discussed, I think majority of these things have already been discussed by the panelists. So these are various techniques which you can do to really handle this kind of a situation.
Yeah, I think very quickly, Mohnish, I think we won't now because I would agree. I think in our scenario, in the Indian scenario, it's better not to have a grommet because your hygiene and various things are very variable. So, and anyway, when you're doing a cortical mastoidectomy, posterior tympanotomy, you're creating so much ventilation. So that's why I've never had to put a grommet in. So I think, sorry.
I perfectly agree. I have refrained from doing it myself, and I've never done a cochlear implant with a grommet in situ. So yeah, I'm pretty worrisome. Yeah, Kranti.
So basically in the video, you just make a small supramental well, but in cases here or things like that, then I would like to extend that mastoidectomy basically.
Yeah, point. Yeah, point taken. So for those who are doing the Varia technique, and that's a important point, you would probably be happier doing a kind of a bigger enterostomy to handle this kind of a situation. Right, we saw a CSF gusher being described by Medikeri sir. Now can just somebody, maybe Preetham, if you could outline the various things which you do.
The video is sort of not playing, but I understand that this is a CSF gusher which is occurring as soon as we have opened the round window and it's filling up the whole of the cavity. So this is a CSF gusher, and as Medikeri sir put it up very well in his talk, the major important thing here is to have a wide opening or a wide access and patiently wait for the pressures to come down. And once the pressures come down, then you use a full banded electrode, because obviously you're looking at an IP1 or a CH2, and then there is a modulus defect here. There is a wide connection between the subarachnoid space and the cochlea. So you would use a full banded electrodes here and then insert them in and make sure that you plug the defect very well. And there should be no leak further occurring on the table. So if you make sure of that, then more often than not, you will get away.
Yeah. So, we heard Dr. Medikeri's talk on this, and to put in these points, remember to do a bigger cochleostomy than usual, so that you have good enough space around the electrode to seal it off, and that would actually be helpful. Am I audible?
Yeah.
Yes, sir, you're audible.
Perfect.
One more point.
So we have had, yes, sir.
I at the end I use T-seal to completely seal that.
Yeah, so
the tissue.
People have used glues, and I've used glue, I've never used it. But if for any reason the gusher is not stopping, you would actually love to seal it off with a tissue glue so as not to have any problems because of that later on, right? Do all of you use tissue glues?
So basically tissue.
No, I don't use.
Yeah, so tissue glue is, you need to plug it completely nicely. Tissue glue is just to keep it in place. Tissue glue won't help to seal anything. That is very
Correct. Absolutely.
You do not have to, which is a very common, people think that tissue glue sorts it out. You have to seal it completely. Tissue glue holds the product together, ultimately to form it and gives it a base for healing.
Absolutely. So the first layer of repair is the most important out here. And so just about the malformations, as Preetham mentioned, it could be in IP3, IP1, and CH2. And we heard Dr. Medikeri talk the same in his talk. When we have the SMS classification, and that's the 3B, when you have an absent lamina cribrosa and an absent modulus, you actually land up with a CSF gusher. Now, if I were to ask Dr. Medikeri here, intraoperatively, if your assistant calls you in that electrodes are not going in completely and some resistance is being felt, what do you do?
Yeah, usually I check the scans once again and see for if there is any fibro obliteration of the cochlear turns. That will just make it sure. And if it is not there, then if it is either sometimes what happens, the tip of the electrode would have been abutting against the lateral wall, something like that. I may have to withdraw it and maybe rotate it in my finger and then try to push it further. So many a times when we are done this maneuver, so it has gone, unless there is any obstruction inside the cochlea, majority of the times. That is what we do.
Now, anybody wants to add to that? These are important points. Look at the radiology, remove it, withdraw it a bit, and then rotate it, use a different axis. Anybody wants to add to that?
The trajectory will be a little different. So if you make it, I think you are able to do it.
Yeah, check the trajectory. If you may want to irrigate or flush some steroid into the cochlear canal. I haven't used Elon for ages now.
But has someone shifted from a round window to a separate cochleostomy for a partial insertion in the same? Same patient.
Not unless there is ossification or something. If the anatomy is normal, then not have to do that.
Okay. So I think this is exactly what, Medikeri sir mentioned, and, we actually, all of us would follow that. Now, important point here would also be, if still you are facing resistance, don't try to push your electrode in.
Yes.
It may actually be worse than having a few electrodes outside the cochlea rather than getting inside. Now, if I were to go to Dr. Kranti here, you have your good insertion, but an impedance shows a high impedance or an open circuit or a short circuit. What do you do here?
Such cases, even if, so this is important, and in such cases, I immediately get my orthopedics OT to my ENT OT and do an intra-op radiology to see what's going on. Because I have had full insertions, well, as per your site, what it says. And then I would check what's happening. It could, the tip would have rolled over or something, you can have various, you can have kinking, you can have tip fold overs, so you need to see that exactly intraoperatively, and that's where these intra-op monitoring becomes important. So you should have a CR or a fluoroscopy backup in your OT whenever. So I follow us when you have good impedances and good potentials and all of it well enough. If you are not having good potentials or even short circuits, you need to do your intra-op radiology and go back again and see whether your insertion was.
What do you consider as worse, the open circuits or the short circuits?
I think the short circuit.
Yeah. So,
Mohnish, these are, if I may add, so these
Yes,
are
sir.
different situations.
Yeah.
So the first thing is that you make sure that the cochlea is not dry, and so if you have high impedances, it could just be the simple lack of adequate fluid in the cochlea. So you can irrigate, wait for some time, let some more perilymph collect in the cochlear canal, and the impedances may come. Again, we are assuming this is normal anatomy. Because with abnormal, you can get various things. So that's the first thing you have to do. An open circuit again is just very high impedance at that point, and that could be as something simple like an air bubble around that electrode. And again, that may not worry me. Yes, as Dr. Kranti said, get imaging just to be reassured, particularly if it's at the end, the tip, then you want to make sure there's no tip fold over or kinking. So that's that. Short circuit is a different situation. Short circuit means that there could be either an issue with the array, that there is an electrical problem with the array, or there is some form of kinking that two electrodes are in contact with one another. So that's the worst scenario to be in. And if that doesn't settle, then these electrodes if you decide to leave that and not replace the electrode array, then those may have to be flagged off.
Perfectly put. So I think that's something which all of us will agree to it. I mean, open circuits is just pure high impedance and will usually settle down, and hopefully will. Short circuits may not. Okay, now tips and tricks. Now Medikeri said touched upon this too. But if you have a fibrosed or ossified lumen, Preetham, what do you do? What are your tips and tricks for the assistant or a friend of yours who is doing it?
Okay, so ours is a sort of a protocol that we follow. The first would be to usually an obliterated round window. We would just drill off that area and then try to identify the round window. And if you open it up and you don't find a lumen, you will drill along the basal turn, trying to find the lumen. So that's at a maximum. Again, we know that 8 millimeter. If you're not finding a lumen over there, the next step would be to go for a scala vestibular insertion. That is, you would do a cochleostomy antro-superior to the round window. So that's the next step that we do. If you don't find a lumen there, then we go for the middle turn cochleostomy, which Medikeri sir showed also in his double array insertion, where you go just vertically anterior to the oval window and try to create a there. And then obviously theoretically there's an apical cochleostomy also, which is described, but I have no experience, and obviously the literature also doesn't go. And this is our sort of a protocol that we follow.
Good. So I think that's a good brief overview of it. Just to add another thing is the depth gauge, which can be used. Dr. Amit Kishore, so you want to say something?
Yeah, I was just going to say this. What you already mentioned, Mohnish. I would ensure that I have a couple of depth gauges, and in this situation, I would even use a stiffer electrode, stiffer depth gauge, electrode depth gauge, as a stilette, so to speak, is to
Yeah.
put that in first and break some fibrosis, and then put in my actual electrode if on the MRI I'm seeing some fibrosis. And very recently we've done a few situations like this, and then that has allowed my heart rate to come down because we've been able to get the implanted.
Yeah. And another thing which
Amit, can I
yes, sir.
ask one question?
Please.
What is your experience with this complete obliterated cochlear drill out procedures? Because I don't have any experience.
Okay, so we have never been able to handle those. In fact, there was one patient whom we ultimately ended up doing an ABI. So that's the only ABI which we have done.
It's really not very great, Dr. Medikeri. So if I have a complete ossified eye, because we have ABI at a center, I would offer them an ABI rather than trying to do a drill out if it's completely ossified. Poor results.
Pretty much same. And that's the one thing which I would actually also add is, picks are than burrs here at times, because a burr would actually drill through everything, even the softer ossification inside the cochlea. So picks would actually not lead to loosening out the lumen here. Now, this is what a depth gauge or an insertion test device would look like. This is of a particular company. Now, the reason why I brought up this is what is the company's recommendation is if 8 or more bands remain outside the cochlea. So that's out of a 22 dummy, electrodes. If 8 or more remain outside, then they recommend a double array to be used, which is not available, right? So that's an 8 or more out of 14 or 22, sorry. Out of 22, if 8 or more are outside, they do not recommend putting up a cochlear implant, putting in a cochlear implant. Do all of you agree on that number? Do you follow this in your institute? That's a company's advice, right? 8 out of 22. All of you agree on that? Yeah,
approximately, I would say if I get half of them in, then that's
okay.
Yeah, so it's kind of 11-ish. Yeah. Okay, so it's been a divided opinion whenever I discuss this between half and 2/3 is what people would actually, kind of be happy enough to use. And this is just to read out what the company's recommendation is. I would not play this video because I'm pretty sure this would not play considering my internet connection. So let me just skip that, and these are double arrays, which I have never done it, and cochlear stenting, which we also touched upon in the previous talk. So this is again, which is feasible if you are, looking at a possible ossification and waiting for the funding. Right now, this has happened to me at times. Dr. Muthukumar sir, if you get a good insertion, however, you do not get any ECAP thresholds, what do you do now? Normal anatomy, you are happy, you don't get any ECAPs.
So we also do the ESRT.
Yeah.
If there is no response in the ESRT, and if you are confident that intraoperative radiology is important, and if you are sure that the electrode is in the cochlea, we close it, and then after we closure, we get the responses. This especially happens more commonly in which we do the metal company, because it takes some time sometimes. But
I think two important points which Dr. Muthukumar mentioned. One is if you are happy as a clinician, as a surgeon who has done an insertion in normal anatomy, you have to actually take a final call on it, and especially the role of intraop radiology here becomes very important. If that shows a good insertion, and again, the second thing which he mentioned was repeat it after closing, right? That actually would many a times give you a good result, because all the electrodes are now really, the ground electrodes are touching the bone where they're supposed to be. The things have settled down a bit, and that would usually actually be happier. Now, coming to the thing which he mentioned, let me go to the senior most person here, Dr. Medikeri sir, right? Intra-op radiology, do you do in all your cases?
No, I don't do intra-op radiology in all the cases. I do in all the anomalous cases. Or now, especially after started using is 632 electrode, that slim radiolar electrode, to avoid the tip fold over. Now I've been doing intra-op. We get the mobile X-ray unit and we get immediate picture on the laptop. So otherwise, most of the times I am happy because I do the impedance telemetry, NRT or NRIs, and then I do ESRT in all my cases. Okay, and if I'm completely comfortable with all these things, then I do X-ray, post-op X-ray on the next day.
Wonderful. So does everyone agree on this, or is there somebody who would still
But
do it?
anomalous cochleas, one need to do intra-op and make sure that things are all right.
So if I may, just say anomalous cochleas, anomalous in the form of either malformed or ossified, right? Or in patients in which you are not getting a good E-cap threshold or good impedances, or maybe in revision surgeries. I don't know, for revision surgeries you would still go ahead, right? Other than that, is there anyone in the panel who is still doing intraop radiology for all the patients?
I do intraop radiology for all my patients. It's an institutional protocol. So we do C-arms in all our patients.
Yeah. So sorry, Kranti, you also, right?
I don't do intro. The indication which Medikeri sir told is what I follow.
Yeah.
And I add one thing in the slide because when you're doing these impedances and not getting impedances, there are times when your audiologist will keep doing the ARTs and RTs, and what happens is the nerve goes into fatigue also. So you need to give them time, and that's when we had a workshop, and then we had this patient who was not having any threshold and did not have it post-operatively. Also, there was a lot of blood and all that, and we got to receive everything at the time of switch on. So that's also important. So if you're sure, you can close the patient.
Yeah. So as a protocol, it's when it's an institutional protocol. Dr. Preetham mentioned getting a radiology is sometimes followed, but I think everybody in the panel would also agree that when you're starting off with your cochlear implant surgeries, all these panelists have done hundreds of cochlear implants, right? So they may not land up doing radiology, but in initial few cases, I think everybody should get in radiology, intraop radiology done. That's something which is still imperative for the initial cases. With experience, you may not. Now, this is one of the ways, by which you can do it. This is a modified Stenvers. You turn the head to 45 degree, have vertical rays coming in, or post-operatively, again, this is something which can be done. The Townes view would be something like this, and this is again can be done intraoperatively as well as post-operatively. And this is how you use actually kind of to measure the things. So if you look at this is your electrode array. That's your vestibule right here, and then you have the superior semicircular canal and the lateral semicircular canal being shown here, right? So this is what it looks like if you're trying to read your radiology, and we have also labeled it in this particular diagram which follows. Now, if you look at these three, right, these are intraop images, right? Dr. Muthukumar, can you just comment on these three images? And these are a bit tricky images, so it's not just for a few fun questions here.
I think the lower one on the right side, it has gone to the internal acoustic meatus, I believe.
Yes, it's not in the cochlea for sure, right?
Not in the cochlea.
Yeah. So that's yeah. Anybody wants to comment on those?
The lower one on the left side, I think it is in the common cavity.
Yeah, so it could be in the vestibule. So the reason why actually, the reason why actually because this can be rotated, right? Many times you have to rotate the CM really get a good picture. So if I were to really, go ahead and put it like this, this is how exactly it was. And if you could make out, this is your lateral and this is your superior semicircular canal. So it's actually gone in the vestibule and it's just kept there. And similarly here, when Dr. Muthukumar mentioned, this is actually gone into the superior semicircular canal. And this is how it is actually lying and going up there. So the CM images, they can still be confusing at times, and therefore, and in both these conditions.
I think we lost Dr. Yeah. So I think I will just continue forward with what Dr. Mohnish was telling. So if he's basically trying to put forth the point that you should be able to understand your images, because it could be still having that lovely turn that you want to anticipate on a CI, but that could be in the superior semicircular canal, that could be in the vestibule. So you need to understand your radiology well and identify these things. I think Dr. Amit Kishore sir or Dr. Medikeri sir can also add their experience with this.
Yeah, no, I quite agree with what you said, because there are occasions sometimes I think where they have drilled through, or they have sometimes identified hypotympanic cell as the round window and inserted there, and it had gone into the hypotympanic and gone to the eustachian tube also sometimes. And even some people have drilled through the cochlear lateral wall, and then it has initially, I had once like that. It had gone through the cochleostomy and then gone through the lateral wall of the cochlea out, and then it had gone to the crotch area. So those things can happen. So the one has to be very careful in evaluating these things. And of course, another one of my mentee, when I was not there, he had put directly into the vestibule. So it had very surprising how it went into because it had gone into the posterior semicircular canal. So when I presented this, somebody was asking me, unfortunately, I didn't have that picture, which he had not given it to me anyway, but I had seen it before the surgery, re-implantation. Somebody had suggested through the oval window, he removed the stapes and put it through the oval window to put it to the vestibule. From there, it had gone into the posterior semicircular canal. So these things sometimes really they are nightmares. I don't know how the things can happen. So it is better always to confirm it on the OT table if it is possible, whenever there are anomalies or when things don't go according to your way.
Yes,
And,
so that's where you told about ESRT is very, very essential in this.
Yeah, very essential. Yeah.
Yeah.
And
So we have
one more
yes,
point I just want to make, Mohnish, about this high impedances, short circuits and all. So this I have got recently because I go for mentoring. Now the Karnataka state government also has started. I go for mentoring many of these medical colleges also. And there are new people coming, these persons who come from the company to support. Some of them, they don't know that the implant, before it is being opened and given to the surgeon, it has to be tested. So when it has to be tested, they should have all open circuits, which they have to test and give it. So if anything goes wrong on the table, unless if he is not tested, then I'm not sure whether the implant is proper or not. Whether if there is any short circuit happening here, was the short circuit there beforehand? This is occurs very rarely, but it happened to me recently. So then when I asked, that person was flabbergasted. He didn't know that implant has to be tested before giving it to us. So we take it for granted. So this is one of the points I think one should keep in mind.
Am I audible now?
Yeah.
yes, sir, you're audible. We
Yes.
were just discussing the different aspects that you mentioned about in your X-rays. That's it.
Sorry for this again. Now, if your X-ray actually shows something like this, Dr. Amit Kishore sir, you have
This
Yeah.
this is what Dr. Kranti had mentioned, a tip fold over. You can
Yeah.
see that the tip has folded over there. It's very clearly shown. So
Now what do you do?
that's what. Well, it depends on the electrode array. This looks like this is, well, your image is different from the X-ray. So if the implant is such that can be reinserted, then I would withdraw and reinsert the device.
Okay. And if you come to know about it post-operatively, what do you do?
Well, you would have to flag off those electrodes.
Would you
Or you have to go back and, well, you have to discuss it with the patient and then go back and reinsert it. That's the other option.
But what's your first preference then?
My first preference would be to ensure that this is picked up on the table.
Yeah, that's right. That would be the best scenario. What may happen at times? What may happen at times in this kind of a scenario is, your audiologist may actually not be able to tell you if you have a tip fold.
Yeah, you can't, because you will still get ECAPs on that. Unless you're doing field measurements, which of course we don't do as a routine. This can be missed.
Exactly.
This can be missed. Maybe you might get a short circuit because you can see the tip is touching the 7th electrode, so you might get a short circuit on that. But yeah, in this situation, it's a difficult one only. I mean, ideally, it's hard to tell the patient, look, this has happened and I'm going to go in. But I would like to do that, because otherwise this guy is going to go around all his life with an electrode array that's folded over. Certainly it's not good. It's not good advertisement for your technique in the first
Not a good
place.
advertisement for sure. I have lined it up, and I have not actually kind of revised this particular patient. Right.
Yeah,
and
but you can opt to flag off some electrodes.
So that's important. You will actually have to flag off, because otherwise you create issues. Anybody else, have you revised this kind of a patient?
I would just want to know, sir, if you don't mind. So what is your limit? How many electrodes are you okay with flagging off?
Good point, Preetham. I think it again comes to discussing this with the audiologist really, and seeing how many electrodes they need for adequate frequency allocation. Depends on which device you're using, whether using a device with 12 pairs or 22 or 16. So the number of I don't know if scientifically there is a number that is considered to be appropriate.
There's no number, Preetham, which is mentioned, but if you have to flag off, you would actually not need to flag off all these. For example, this particular figure, you may not need to flag off all the 7 electrodes.
Only the ones that are only the one which is touching and
So that's
usually. I've been in this situation once, Mohnish, where there was a colleague who was doing who did this, and then the post-op X-ray showed fold over. In that situation, we discussed, and we actually discussed with the father, with the family, and said, look, this is what has happened, and we would prefer to reinsert this. It was picked up on the post-op X-ray. In fact, he appreciated the fact that we were honest and said, look, there was an issue and we would like to do this. So the next morning, I went in and I helped to reinsert the array. That's the only situation I've been in.
Interesting. When I were to go about and reading the literature, they would actually say that it's pretty okay to leave it like this. But yeah, that's a divided opinion. Kranti, you wanted to say something? Yeah? You are muted. Yeah.
Using to reinsert these electrodes and it has rounded over, already happened. Isn't it difficult to go back again and retain the whole sort of that it cannot happen again? I don't know. Like, do we implant with a new implant or use the same electrode and then?
Well, Dr. Gandhi, the only situation I've been in this once, and we use the same electrode, and it was fine. This was a 632, and we had the sheath, and we just put it in we had kept some sheets. It was in the kit, so we did the. It depends on the electrode that you're using.
632, and it was.
They're notorious. 632 is notorious for.
My third attempt before I could get it all right, so it was not something which I really loved. So tip foldovers, just to for the audience, it's about 1 to 2% incidence in literature. As Dr. Amit Kishore mentioned, the electric field imaging and the SOE testing are what are required during electrophysiological tests. Your routine ECAP thresholds and impedances may tell you. There are various associations which have been included. The right side CI has been seen to have more number of tip foldovers than the left. Perimodulars, we discussed, that has higher incidence, especially 632s. And round window insertions, again, have been known to be associated more with tip foldovers. The treatment includes either of these, right? Observation follow-up as the first, selective deactivation of flagging off of overlapping electrodes, and revision surgeries, right? Now, let's just take off this, and this is another case which I wanted to discuss. You get an X-ray like this. Now, what do you do? Anybody wants to say on that?
I would immediately go for I'm decently sure that it's not there in the cochlea or it's normally positioned there. I would definitely go for a radiology or CT and then look where exactly it is, and then decide on the further course of action.
Yeah, so that's what Preetham is telling is very correct. In such cases, better go whether it's CT or CBCT, but you'll get it where it is in actuality, and then you can.
Yeah.
So if this is a normal rat, it needs to be revised after imaging.
Yeah. So this is what the imaging was showing.
Gone to the IAC, I think that one.
Yeah, gone. This is the CT scan. You see the electrodes going well in. Right.
I think it's gone past the cochlear to the other side.
Yeah.
Carotid canal.
So this is where it has landed up inside it, and so when you're having such an anomalous kind of trajectory of the electrode area, as Preetham and Kranti and everybody mentioned, you need to get a good radiology done. I'm not going to play this video. Let me just try playing this if this works out. Is it really
I
playing?
had one exactly like one exactly like this, which I had revised.
Yeah.
So, and we took out it had multiple places kinked.
Yeah.
Take it out and use a new implant. And I did a round window insertion in that case. I think I showed
Okay.
some video in some of the conferences.
Yeah, so this
Where,
is
but before putting the new electrode, again I used the dummy electrode and took a CM picture and confirmed that it is going into the cochlea, and then opened the new electrode.
so in this particular patient, something similar was there, but we had to use the same implant. We didn't have an option of using the other electrode here. And because of the previous surgery, there was already a posterior superior perforation. Incudus stapedial joint was also dislocated, and the whole of the promontory had been badly drilled out. In fact, we couldn't find any lumen in the the scala tympani or the scala vestibuli. And anyhow, we had to kind of repair the perforation, so we elevated the flap off, and we ended up doing a middle turn cochleostomy here, which you also showed. This was, sir also mentioned, is just going 2 millimeters interior to the oval window. And then, we threaded the electrode through the posterior tympanotomy, and then, went inside electrode by electrode, just pushing it in. And this was one of my first cases of middle turn cochleostomy. And, and Dr. Mohan sir was actually instrumental. I called him up intraoperatively to, discuss how to handle this. And these are the impedances which we got. Now, we need to remember this could be actually a retrograde or an antegrade insertion. And your audiologist would actually want to know that. And this is, as you look at this, the basal turn is not showing any electrodes, the only electrodes which are seen in the middle and the apical turn. And that's where it was. And, this is how the various anomalous insertions can be present. So you actually need to be knowing all these, land up with the cochlear implants. So, the take home message, the first important message would be that, your electric network connection can be really bad, as it was happening with me. So you need to handle that for sure. We have a strike of doctors, we have a strike of electrical network connections also, but the cochlear implants, never celebrated too early. This is our favorite, slide, and never lose hope too early. Because there might be conditions where never leave the job. Be the patient till the job is over. Right. So this is important, and I will actually end with Dr. Mohan's statement here. And what Mohan says, one of the statement was that all these patients are going to outlive the surgeons, right? And we make sure that we don't just operate upon them and leave them. They are going to be there even after us, and then come back to the students who are being taught by us. So let's not make their job any more difficult. So thank you very much, and once again apologize for the issues with the network out here. And if we have any questions, we may discuss those. We still have about 5 to 7 minutes. Yeah, Preetam.
Dr. Mohnish, I had a question to you. Dr. Medikeri sir showed that he did a middle turn cochleostomy through the posterior tympanotomy, and you showed that you did it through an anterior tympanotomy. Which is the best way to go forward? Should we do an anterior tympanotomy and then do a middle turn, or we can still go on and do a middle turn cochleostomy through the posterior tympanotomy?
We can easily do it through the posterior tympanotomy. The only reason I did it through after elevating a flap because the patient already had a posterior superior perforation. So I had to repair it well. So that's only in this particular patient that I ended up doing, elevating a flap and then doing it. Otherwise, the rest of the cases, that's around 3 or 4 others, I've always done it through the posterior tympanotomy. You may actually remove the incus bar completely to actually get a bit of this showed, right? Medikeri sir, you agree with it, right?
Yeah, absolutely.
Yeah.
So when I did, I called you up and then you told me to do it, and then I did it through posterior tympanotomy. But I was just curious, like.
I know. So
thank you.
I think it can be handled easily through your posterior tympanotomy if you're doing it. If you're doing varia, you already have a good view inside, and so we can see smiling Kranti out there. Okay, so do we have any questions in the chat box? I had a bad connection, so I don't have any questions. Dr. Vijay, do we have any questions, or if some of the panelists can read those in the chat box if we have to discuss any questions?
Can I do that for you, Dr. Mohnish?
Please.
Is that okay?
Please do.
Yeah. So the first question, I think Dr. Arun Srinivasan had asked, and you have asked that. Dr. Ramesh had asked. We had spoken about IV mannitol. Dr. Arun Srinivasan, your experience with ANSD.
We answered.
We discussed this.
We
answered that question. Immediate post-op treatment in these gusher patients. Dr. Palniyappan sir has asked this question. Immediate post-op treatment, sir wants to know.
Immediate post-op.
Yeah.
So anybody wants to take that?
So as per Yeah, so as per our protocol, we would introp also keep the head end elevated. We would also start them on acetazolamide, and we would have a huge threshold if at all there is any leaks occurring. We have a huge threshold, but a lumbar puncture is always there as a backup for us, and we will just continue the acetazolamide and open up the dressing a little bit early to see if there is any soakage which is occurring from the external auditory canal. That is very important for us. And if that is okay, we will just keep this open, keep the dressing for a longer period of time.
Yeah, and good anti-meningitis doses.
Yeah, good anti-meningitic doses. Yes, I'm sorry.
Yeah.
Doc. Yeah, please. Sir.
Sorry, go ahead.
Yeah. So there's one question, Dr. A. Akhtar, what alternative to cochlear implant? I'm not sure in which context he has asked, but Dr. Arun Srinivasan has asked role of unaided versus aided
TAPs, cortical responses.
Oh, TAPs, or cortical responses versus EABR in ANSD for candidacy for CA. This is a very nice question, I think,
Okay.
from it.
I think Dr. Amit Kishore would, or Dr. Medikeri maybe probably would.
Amit.
Yeah.
ANSD.
So so as we already mentioned that we can use EABR, we do use cortical, and yes, we have used. So we're dealing, of course, with kids who are not responding. So there is a role for aided. We rely a lot on aided responses when we are, looking at. So it depends. Okay, let me just take a step back. Candidacy for CI, we have got to decide whether we're talking about ANSD. That's probably what it is. But sometimes we also use aided responses for when we are discussing or trying to decide between ABI and CI in children with hypoplastic cochlear nerve. So in that situation, we would use aided responses, but we use behavioral aided responses, not so much the cortical responses. Here we are talking about ANSD, and yes, we do use cortical and we use aided cortical responses as well. But that can be tricky to set up. But if you get responses on the transtympanic EBR, you can't. It's hard to do aided. You can't do aided, and we will not be able to do that. But cortical responses, you can do those responses. Yes. So if you're getting good cortical,
Tricky
So,
question.
yeah.
Go ahead.
Yeah. So the next question is by Dr. Palniappan sir again. So he's telling that the facial nerve is exposed. You have a facial recess. He has extended the facial recess, and still the round window is not seen. Means he's talking about a rotated cochlea or a difficult access cochlea. What to do next?
Already answered this question in one of the slides which Mohnish has put up. No.
Yeah. Maybe just to outline again, one of the ways would be to fracture the canal wall. First of all, thin it out as much as you can, fracture the canal wall, push it interiorly, right? Don't, kind of injure the skin. That's very important here. Rotate the microscope and the head of the body patient so that you can actually look deep inside towards the round window, right? This is important. And then remember the relations about 2 millimeters inferior to the oval window. Try looking at that place. These are a few things which we can actually do. And one of the things which I actually do as a practical tip is, add in a drop of saline over that area of round window, and the refraction which actually, helps you to look at, where the impression of the round window is, and you can actually specifically go there, try to locating a round window, right? So that's what, one of the things which I also follow.
To add to it, sir, I think the endoscope sometimes helps. So so you can also use an endoscope to sometimes localize.
Not that I've ever used it, but yeah, that's something which I know you do.
Pediatric angled endoscope.
Yeah.
Yes, sir. So that's one thing. So the last question Dr. Kaku has asked, does intraoperatively C-arm has any role in this scenario? I'm not sure which scenario, I'm not sure, but
become the same scenario, I think, where you cannot visualize the round window. I don't know whether on intra you can see the round window. It's not.
C-arm is not going to show us the round window or any other anatomy. It's just going to show us the electrodes. So I don't think C-arm would have absolutely any role in this. Any of the other people.
Something else, I suppose. Must be something else for
maybe.
Sure. Yeah.
I don't see any more questions.
It certainly has a role as we've already discussed, has a role in anomalous cochlears, and you can use fluoroscopic guided insertion as well. If you're dealing with an IP3 or just wanting to make sure the electrode doesn't go in the internal auditory canal. I think that's already mentioned. So maybe that's what is talking about.
Yeah.
Yes, sir. So that's the questions that I can access on the chat box.
And one more question which I would like to ask, sir.
Yeah.
Cochlear implantation done very well, switch on done, but no response, no NRT on the table. During switch on, no NRT, sir. But patient is doing well, child is doing well. Behaviorally, the responses are good, responding to sound. Language acquisition is also good, but still no NRT, sir. So is that possible?
No NRT, no ECAP scores.
No.
Is this a normal anatomy? Is it a normal anatomy or a hypoplastic nerve?
Normal. We have a peculiar case, sir. Still the child is doing well. So I just want to point out that this is also happened in one of our cases.
Cochlear and cochlear nerves are normal.
It's normal, sir. The child is also responding very well.
Yeah.
With the AVT and the.
So when
Sir, what I have seen on my personal experience, I have also discussed with Mohnish sir, and he has also guided me in this. So these people, if they have a cochlear vestibular nerve or a hypoplastic nerve, they might not have the good action potentials that can be detected on your ECAP measurements, but they will have responses on behavior audiometry, but that doesn't really guarantee you that there will be good development. So we are not telling them that there will be sound awareness and there will be responses, but I'm not very sure whether they will have near normal or age appropriate growth that you see in a normal nerve. So that's a big concern for me.
Okay, sir. We are following up the case as the child grows. We'll come out with it.
Yes, sir. You're telling, sir. Your experience is obviously more, sir. So I'm just sharing this thing, but it's very rare scenario, sir.
Try changing the whole computer setup and check it with something else.
Yeah, true. Okay, so do we have anything else to discuss, or it's Dr. Vijay? Do we have any questions at your end?
Dot 8 p.m.
Okay, so let me thank all the panelists and apologize once again for the technical issues which I was facing today. But thank you so much, every one of you. It was really interesting and a learning experience for me, and I'm sure the audience.
Thank you, Mohnish.
Thank you so much, Mohnish.
Thank you.
Thank you very much. It was an interesting, very interesting
Vijay.
discussion.
Yeah. Thank you one and all for this wonderful discussion on cochlear implant difficult scenarios and the lecture by our one another Dr. Shankar Medikeri sir. So we have almost more than 600 participants who are seeing it live, and I would like to thank GSK for sponsoring this session. Thank you all. We'll see you next.
Thank you.
Thanks
sir.
very
Thank
much,
you,
Vijay.
Thank you, Dr.
Thanks, everybody.
Thank you, everybody.